Ο επόμενος ομιλητής είναι ο κ. Τσάτσαρης, ο Βασίλειος Τσάτσαρης, ο οποίος θα μας μιλήσει για το Angiogenic factor in the management of preeclampsia. Ο κ. Τσάτσαρης είναι PhD από το Πανεπιστήμιο στο Παρίσι και εργάζεται τώρα στο νοσοκομείο στο Πόρο Αγιάλ. Please, Mr. Tsatsaris.
Είμαι πολύ χαρούμενος που είμαι εδώ σήμερα μαζί σας και θα κάνω μια ομιλία concerning angiogenic factors in the management of preeclampsia. So I will focus my topic on early screening and diagnosis of preeclampsia. So the situation is quite a bit different than trisomy 21 concerning the screening. The prevalence is quite different. So in the United States, the prevalence is higher than Europe, around 2 to 8% according to the risk factors. It accounts for 20% of maternal deaths and 15% of preterm deliveries. And we think that more than 1,000 infants die each year because of preeclampsia. In Europe, the prevalence is lower. In England, in the FMF study, is around 2%, so around 1% in France. So when we say that it's for 5 to 8%, this is probably too high risk. In the world, it remains the main cause of maternal death, and it's believed that 50,000 patients die because of preeclampsia. The problem with preeclampsia is that it's a multifactorial disease. The main problem comes from the placental dysfunction that comes progressively during pregnancy and releases in the maternal circulation some factors like syncytial debris, reactive oxygen species, anti-angiogenic factors like soluble VEGF receptor 1, soluble endoglines, several cytokines, and these factors are responsible for the endothelial dysfunction that characterize preeclampsia. The placental dysfunction is also responsible for fetal consequences like intrauterine growth retardation and intrauterine fetal death. What causes placental dysfunction? We know that there are many causes, in fact, and some of them are here, but there are many other causes. Usually we say that it's abnormal trophoblast invasion and abnormal vascular wounding of the uterus that causes preeclampsia, but this cause here is probably responsible only of the early onset preeclampsia associated with IOGR, which is not most of the cases. There are other causes like post-mature placenta, twins, diabetes with large placentas, thrombosis in the placenta, and some infection, and it's now well known that CMV may lead to preeclampsia. One of the major advances in the pathophysiology of preeclampsia is the fact that we realize that soluble VEGF receptor 1 plays a major role in this disease. Soluble VEGF receptor 1 is an anti-angiogenic factor which is released in maternal circulation that binds PLGF and VEGF. These two factors are angiogenic factors that are survival factors for the endothelial cells. And during normal pregnancy, there's a steady state between this soluble VEGF receptor 1, which is produced in large amounts by the placenta, and PLGF. In patients with preeclampsia, there's a high increase of soluble VEGF receptor 1 in maternal circulation, which leads to a decrease of PLGF and maternal endothelial cell injury. In 2004, there was a major paper published in the New England Journal of Medicine showing that the abnormal production of these factors occurs many weeks before the onset of the clinical symptoms. So you have here the production of soluble VEGF receptor 1 along pregnancy, and here the PLGF. You have the black curve here corresponding to patients with preeclampsia, and the blue curve here corresponding to patients with normal pregnancy. And as you can see here, there's a massive increase of soluble VEGF receptor 1 and massive decrease of PLGF in maternal circulation in patients with preeclampsia. The most important point of this paper is the red curve here. So this red curve corresponds to patients who do not have any symptoms at the time of blood sampling, but who later develop preeclampsia. And you can see that there's a significant difference between the red curve and the blue curve here, very early in pregnancy, showing that these factors could probably be very good predictive factors of the disease. So after that, many teams try to validate the place of these factors in risk scores in models predicting preeclampsia. So what do we need as clinicians? In fact, we need screening tools that will allow primary prevention of preeclampsia, for example, possibly aspirin, to reduce maternal morbidity, to reduce, to induce prematurity, and to avoid some unjustified interventions. The main paper was published in 2009 by Kypros Nicolaides and his team, showing an excellent detection rate of patients here with early onset preeclampsia, but a quite poor rate of late onset preeclampsia and gestational hypertension. So these results were very encouraging, showing that possibly this test, with an algorithm here combining clinical parameters, PAPA, PLGF, and uterine Doppler, could help us to predict the onset of preeclampsia. The problem is that many studies came after that showing that these tests are probably not so good. So I will not show you all the studies because there are many. There's one systematic review meta-analysis here that I will present to you today, and 2 or 3 very recent studies showing that these screening tests are probably not so good. So this is a systematic review that was performed by a very good team in Canada, in Quebec, and they made a systematic review of all these studies dealing on the prediction of preeclampsia. And I will show you just 2 figures of this systematic review because they are quite well presented. So you have here 4 kinds of studies, those that were looked at first trimester biomarkers and first trimester Doppler, first trimester biomarkers and second trimester Doppler, early second trimester biomarkers and second trimester Doppler, late second trimester biomarkers, and second trimester Doppler. You have here the results in a low-risk population. You have here the sensitivity, and here 1 minus specificity here. And you can see the false positive rate here. So you can see that in low-risk population, the first trimester, these tests are not so good for the prediction of preeclampsia. They improve when you go later in pregnancy, but if you use a test late in the second trimester, you will not be able to use some preventive strategies. So the point is to try to remain in the first trimester. When you look at high-risk population, you can see that the predictive value of this test increases, but anyway, in this patient, usually these patients are already the patients that have a prophylaxis by aspirin or sometimes something else. So now the next studies, the recent studies, 2012, showing the utility of uterine artery Doppler in a low-risk population, and this is an important thing because there's a big mess in the literature concerning the type of the population, and it's very difficult to look at the results of these uterine Dopplers and the performance of the uterine Dopplers. So you can see that in a low-risk population, doing a uterine Doppler in the first or early second trimester, the predictive value for preeclampsia, whole preeclampsia, not early onset preeclampsia, remains very low. And this is probably due to the fact that it's a multifactorial disease. This is another paper published in the BMG in 2011. You can see here of the prediction using just clinical parameters, and you can see here that the performance, and this is the conclusion of the study, the performance of the clinical parameters alone is not good enough to be used in a test in the first trimester. This is another study focusing on nulliparous women, which is probably one of the most interesting population. 2,400 patients with a quite high prevalence of preeclampsia, 7%. And you can see that this study, including clinical parameters and biomarkers, show quite low performance of the test. And the conclusion is that the model did not define sufficient utility for the prediction of preeclampsia. We also did in France a study in 8,000 patients, So we're publishing this study in the next months with a low prevalence of preeclampsia, 1.6, and using clinical parameters and 4 biomarkers. We look at PARP-A, PLGF, inhibin A, and salt blood VEGF receptor 1. And you can see here that when you combine maternal parameters and biomarkers, the predictive value appear to be quite good, but this is not in the first trimester. It's between 14 and 18 weeks of gestation. So we now need to see if we put this test in the market and we evaluate the benefit of aspirin, for example, in patients that have been selected by these markers, the prevention is effective or not. The other thing that we need for our practice is a test to identify patients that will develop preeclampsia a few days or a few weeks just before the onset of the symptoms. And probably here we are closer to clinical practice than in early preeclampsia, early screening, excuse me. So we need this test to refer patients to specific centers to organize the follow-up of the patients with specialists in fetal maternal medicine and to eliminate and reduce unnecessary intervention, especially hospitalization. So the first study was published by the team from Anand Karamunchi in Boston, showing that you have the row curve here of the ratio of soluble VEGF receptor 1 of a PLGF, and this ratio performs better than all the other parameters, the clinical parameters, or the uric acid, or the creatinine ratio, or the systolic blood pressure. So it performs better than the tools that we have at the moment. And when you have a high ratio, you can see that the most of the patients deliver in the first week after the test. We did a study also with the PLGF alone, showing the good performance of the PLGF alone compared to the other parameters. And there's a very recent study published in Circulation just last year by an English team. This was a national English study showing that the PLGF alone performs much better than the other parameters that we use in clinical practice. So probably this test with the bedside test that could be available in the emergency rooms could identify patients that would develop preeclampsia just before the onset of the symptoms. For example, patients with just hypertension without proteinuria, or patients with proteinuria without hypertension, and to predict those of the women that will develop preeclampsia. And it appears also a good test for the prediction of abnormal outcome in patients with IUGR. So just to be short, the take-home messages are that preeclampsia is a multifactorial disease, and as I show you on the first pictures, you can see that there are many etiologies that are leading to placental dysfunction, and it's very difficult to believe that we'll have a single test in the first trimester that will be able to identify all the patients with preeclampsia. So some people say that this is not a problem because we just need to identify early onset preeclampsia, which are the most severe cases. But this is not proper because there are very few patients, and when you look at the maternal deaths, most of the maternal deaths occur in patients with late onset preeclampsia. Early screening of preeclampsia is a controversy regarding the performance of this screening. So for the moment, in most of the countries, the test is not recommended in the first trimester to screen for preeclampsia later. And we don't know if aspirin is effective in patients that have been recruited by this test. So there's a study in England now, and Kypros Nicolaides is testing these patients that have been recruited by the test to see if aspirin is effective or not. And probably where PLGF, or the ratio between soluble VEGF receptor 1 and PLGF, could be more useful for clinical practice, it could be in patients with a suspicion of preeclampsia, just to predict the onset of preeclampsia or adverse outcomes, and to discriminate patients that we need to stay in hospital or patients that could go back home, and to avoid unnecessary interventions. So thank you for your attention, and I'm ready for discussion.